that provider has the skills and the knowledge and the competency to do what you need them to do. Now, patients, consumers, aren't always aware of whether a physician or a provider is competent or not. And quite often they'll make subjective judgments about a physician or a provider's competence based on a variety of attributes. They may look at things like training, you know, the classic question. Now, doc, how many times have you done that procedure? Or they may value elite credentials. Oh, this person is at this institution, so they must be good. But also things like appearance or the provider's behaviors, and most critically, the way the provider's ability to communicate competence to the patient is important. I highlighted appearance because there was an interesting study that came out a couple of years ago in the Northeast, where they asked a variety of patients in public and private clinic settings, dermatologic clinic settings in the Northeast, what they felt, what characteristics they felt were important in their providers and were important that enabled them to feel that the providers were trustworthy. And these are some of the desirable appearances from this survey, that they wanted physicians to wear white coats with their name badges, that they wanted men in dress pants, women in skirts or dresses, they wanted dress shoes and traditional hairstyles. Now remember, this is the Northeast, and I'm not so sure if the same sort of qualities would come out in the West and California, but nonetheless, this is what they identified. As opposed to, for undesirable appearance, they did not want to see their providers wearing sandals or clogs, tennis shoes. They didn't want men with earrings or blue jeans. They didn't want men with long hair. They didn't want anyone in blue jeans. So this is the sort of thing I mean, that patients will make judgments about the trustworthiness, the competency of a physician based on subjective criteria. And as the commentary for this article said, physical appearances convey the impression of professionalism, which in turn affects the degree of trust. And then lastly, this third category, caring and altruism. This is the perception that the physician or the provider really cares about you, that there's this interpersonal aspect of it that could be a part of a range of virtues: honesty, veracity, again, this sort of caring and empathy, and being reliable or conscientious. So together now, these three ideas of what trust is. So now, what is mistrust? I want to say that it's not just the absence of trust. Mistrust is not a non-thing. It is something. And it's actually very similar to trust. It is a form of trust. It's parallel in its construction, and it's a response to the similar sets of circumstances that we've just talked about, this idea of entrusting competence and caring and altruism. And then lastly, what is trustworthiness? Now, we identified that patients will trust you based on one of these three categories of trust. So trustworthiness then is, are you those things? Are you really those things? Or at best, can you be perceived to be those things? So, can you be perceived, or are you having no conflict of interests? Are you perceived, or are you competent? And are you perceived as conveying care and altruism, and do you care, and are you altruistic? And how then is trust formed? We've got this idea, and I should take a moment to say, now when I asked you to think about the trust for that person at the beginning of the thought exercise, you came up with that person. You didn't first say, okay, well, trust is entrusting, competence, and caring and altruism. Okay, who is competent? And you didn't do that. You just had this gestalt feeling. And that's what patients go through. They don't do this artificial exercise of deconstructing trust and then coming up with something. So there's another way of thinking about trust now, and that is various ways that patients form these ideas of trust. One, and I won't spend a lot of time on this one, but I wanted to mention, is that sometimes trust comes from some sense of shared values. That person is like me in some way, and I trust myself in that capacity, so maybe I can trust them. This was the sort of trust that might be at play in sort of race and ethnic concordant relationships. So a patient might want to see a physician like themselves or a healthcare provider like themselves. And if that's at play, it might be this identification-based trust at play. But most of the times, trust is a part of something, or develops as a part of something that's called situational trust. That is, it's in response to a real-time experience or situation. So let's explore that a little bit. This is a simplified schematic. So you have a patient, and this patient is about to encounter a provider. They're going to have an experience. And in that experience, they either perceive or have a direct experience of their interests being taken into account, or that this person is competent, or that they're caring. So they perceive the trustworthiness of the provider, or quite the opposite, they may perceive the untrustworthiness of the provider. And then from that, they either trust or they mistrust. So again, it's a real-time situation that is experiential. It's also an iterative process that could be built up over time through experiences, and by correlation to that, it's sort of an idea of how the role of continuity of care in situational trust. Now this is in contrast to another kind of trust, and that's been called dispositional trust. This is psychosocial or cultural-based trust or mistrust that exists a priori in encounter. So before the patient ever even thinks about going to encounter the healthcare system, they've got this predisposition. So this is again another simplified, I emphasize the idea, simplified schematic. So they've got these predispositions, these ideas, these feelings, these thoughts about a particular group, doctors, a profession, for example, or a particular institution, healthcare system, or a particular hospital. That disposition, that predisposition, may even prevent them from even encountering in the first place. It may say, oh, I don't trust, I won't go. Or if they do go and have an encounter, the encounter is probably going to be, their disposition of trust, their trust stance, will probably be unaltered if that disposition is so strong. They'll see what they will want to see because that predisposition is so strong. Now, I want to make sure you get that, so let me just pause a second. This idea that these are thoughts that occur before any encounter. The reason is because, well, there's a sort of a summary of that with the schematic. It's because this is a very important aspect of trust that has been referred to a lot with minority patients. One of the reasons is because of this paradigm case of abuse in medical research, which is considered the exemplar of mistrust among at least African Americans in this country, and that is the United States Public Health Service study on untreated syphilis in the Negro male at Tuskegee. In 1932, a study began, and it lasted for 40 years through 1972, where nearly 400 African American men who had syphilis located in Macon County, Alabama, were enrolled and followed in a study conducted by our federal government, the United States Public Health Service. Now, in the course of the 40 years, these men were not ever treated per se, but they were followed simply as an experiment to learn about the natural history of syphilis. The men were never told that they had this thing called syphilis. They were told they had bad blood. And throughout the 40 years, even when definitive treatment for syphilis was discovered and came into use in 1947, that is penicillin, they were systematically denied adequate treatment, definitive treatment for it. So we can certainly agree that this is an abuse. And one of the study participants who died in 1999, Mr. Herman Shaw, said, "We were treated unfairly, to some extent like guinea pigs. The wounds that were inflicted upon us cannot be undone." So because of this historical event, there is this idea that minorities, in particular African Americans, justifiably should be or can be or are dispositionally mistrusting of the healthcare system. I want to point out that